Good morning. Please state your roll number.
Good morning, sir. My roll number is 1257.
Wonderful. Okay, go ahead. Please present your formulation and
Yes,
management plan of your patient.
sure, sir. Sir, I am presenting the case of Mrs. H. She is a 28-year-old lady. She is a married engineer. She works in a private company based in Bangalore. Premorbidly, she has traits of pervasive feelings of apprehension, the belief that she is socially inept, and with avoidance of social situations, which are suggestive of anxious avoidant personality traits. There is family history of depression in first degree relative and bipolar affective disorder in second degree relative, with history of completed suicide in one of the second degree relatives at the age of 35 years. Married life is of 4 years duration with primary infertility and interpersonal conflicts with the in-laws. She is currently presented with an episodic illness since 12 years, with the current episode lasting for the past 3 months, characterized by pervasive low mood, anhedonia, easy fatigability, decreased sleep and appetite, weight loss, early morning awakening, decreased libido, with a 2-week duration of symptoms characterized by nihilistic delusional belief that her intestines and kidneys are withering away and that her insides are hollow. She was brought to the emergency with a history of suicidal attempt of high intentionality and lethality. There is past history of 4 such similar episodes in 2009, 13, 15, and 2017, with all the episodes lasting for about 3 to 6 months duration with suicidality, and there is no psychotic symptoms in the preceding episodes. 2 of the episodes in 2013 and 2017 were triggered by negative life events. There are no symptoms suggestive of hypomania or mania in the past. She has had a breakthrough episodes with adequate trial of selective serotonin reuptake inhibitors. Historically, there has been a good response to venlafaxine and lithium augmentation. However, she has not tolerated lithium well with the problems of acne and tremors that has necessitated its discontinuation in the past. The current episode is also a breakthrough in nature despite a combination of adequate doses of meritazapine and venlafaxine and despite good adherence. On physical examination, there is a ligature mark observed over the anterior part of the neck, and the otherwise systemic examination was within normal limits. The mental status examination shows retardation. It shows presence of nihilistic delusion with active suicidal ideations and a depressed mood with decreased range and reactivity and impaired judgment. With this, sir, I would like to consider a diagnosis, provisional diagnosis of recurrent depressive disorder, current episode being severe depression with psychotic symptoms.
So your diagnosis is severe depression with psychotic symptoms, current episode. Do you consider any other differential diagnosis for this case?
Yes, sir. Sir, on the background of the family history of a bipolar affective disorder, and considering that there has been an episodic course of an illness and resistance to SSRI and history of good response to lithium, I would like to consider a possibility of bipolar affective disorder with current episode being severe depression with psychotic symptoms. However, in the absence of any history that I got in the previous 1 hour suggestive of mania or hypomania, I would still like to keep the diagnosis as recurrent depressive disorder and clarify the history from the patient and the relative once more informants arrives.
So go ahead with your management plan.
Sure, sir. Sir, I would like to admit the patient in an acute care ward with high support needs after the completion of the Mental Health Care Act guidelines. I would like to ensure that there are adequate anti-suicidal precautions in place with 24/7 continuous monitoring and a close observation. I'll inform the primary caregiver to ensure that the patient does not have access to any sharps or dangerous objects or medications. My immediate focus will be to address the suicidal risk, and then I will actually address the depression and the psychotic symptoms. Regarding the assessments, since the patient is admitted in a high intensity ward, I would like to do the serial MSCs after establishing rapport. Look for the serial in the serial MSCs for the suicidal ideation. I would also like to perform semi-structured assessment for depression and suicidal risk based on the Beck scale for suicidal ideation and the Hamilton Depression Rating Scale. Regarding the investigations, I would like to get a baseline hemogram, electrocardiogram, fasting blood sugar, fasting lipid profile, liver function test, renal function test, serum electrolytes, thyroid function test, and a vitamin B12 level, sir.
Okay. Vitamin B12 level, you say. So can you justify the investigation? Why would you like to do vitamin B12 in this patient for acute care?
Yes, sir. Sir, I would like to assess her nutritional status, sir, through a hemogram and a fasting blood sugar, because her intake of food has gone down secondary to her nihilistic delusions. Considering that there is a need for electroconvulsive therapy, I would like to get a baseline biochemistry investigations and an electrocardiogram. And I would also like to check her thyroid status to rule out hypothyroidism, considering that, in addition to all this, considering that she's a vegetarian and that there has been decreased appetite and weight loss, I would like to consider a strong possibility that there might be comorbid vitamin B12 deficiency, which might be perpetuating the mood symptoms. And therefore, I would like to assess it. Although it might not be immediately relevant, correction of vitamin B12 is a part of my clinical comprehensive plan for the patient, sir.
Okay, go ahead. Proceed.
Yes, sir. Sir, so going on with my acute phase immediate management, in view of active suicidality and the presence of severe depression and psychotic symptoms and psychomotor retardation, I would like to discuss with the patient and the family members about the option of modified ECTs. The need for ECT will be discussed, and afterwards, if the patient refuses consent, I would like to do a capacity assessment of the patient and document the family's consent for the procedure. After they provide the consent, I will ensure that the patient and the family members are explained thoroughly about all the ECT procedures and what is the expected rate of improvement with ECT. And once, I would also like to kind of periodically reassess the capacity of the patient to ensure that she'll be able to consent once she gains the capacity. Once the family consents, I would like to start the patient on modified ECT at the earliest. I would like to consider at least 6 to 9 cycles of bifrontal modified ECTs on alternate days at the frequency of around 3 times a week, while monitoring for adverse effects and look for improvement in suicidality and depression. Once there is plateauing of the improvement with 3 subsequent ECTs, I would like to space out and stop the ECTs based on the plateauing of the improvement, sir.
Good. What assessments will you do before ECT?
Sir, I would like to do a baseline hemogram, electrocardiogram, fasting blood sugar, serum electrolytes, liver and renal function tests. In addition to this, I would like to get an anesthesiologist opinion for pre-anesthesiologist evaluation, including the assessment of the airway and an oral cavity examination. In addition to that, I'll ask the family members for any history suggestive of pseudocholinesterase deficiency in the family, sir.
Summarize or give me 5-6 points on the role of ECT in depression, overall a view.
Sir, ECT plays a very significant role in depression. In fact, to summarize the UK ECT review group meta-analysis evidence for ECT in depression, it showed that the ECT is definitely real. That is, the true ECT is definitely better than a sham ECT, with leading to an improvement of almost 10 points on the Hamilton Depression Rating Scale. Treatment of ECT, whether it is bilateral or unilateral, was significantly better than pharmacotherapy alone, and premature discontinuation was significantly lesser in ECT group rather than the pharmacotherapy group. And bilateral ECT is efficacy-wise more better than unilateral ECT. But there is a greater degree of cognitive impairment in bilateral ECTs. With respect to the brief pulse and the sine wave, although there is no significant difference in the efficacy, the brief pulse ECT is useful to reduce the cognitive adverse effects, especially, sir, when we talk about depression overall and the role of ECT. Whenever there is suicidality, like in this patient, presence of catatonic symptoms or psychomotor retardation, presence of psychotic symptoms, and especially if it is a geriatric age group, or if there is treatment resistance, then ECT plays a very significant role in the management strategy in the acute phase, sir.
Okay. I heard you saying bifrontal. Tell me about the stimulation sites of ECT and which one will you choose in this patient and why?
Sir, the electrodes can be placed either commonly we place the electrodes in the bifrontal or the bitemporal or the right unilateral regimen, sir. But in this particular patient, the selection of the montage depends upon the characteristics such as age, and there is also the component of what is the expected rate of cognitive impairment and how we need to avoid it, and other illness factors such as diagnosis and what is the current kind of targeted symptom domain, sir. So in that sense, we decide whether it is unilateral or bilateral. Bifrontal ECT is usually associated with less cognitive adverse effects, and that's why I would like to choose the same for my patients.
How will you monitor the response? How many ECTs will you give?
Sir, yes, sir. Sir, baseline, I would like to do structured clinical assessments, that is Hamilton Depression Rating Scale, Beck Suicidal Intent Scale, and also daily MSCs. Additionally, sir, I would like to look for the cognitive adverse effects at the baseline and periodically to look for especially anterograde amnesia. And generally for depression, we use anywhere between 6 to 9 sessions of ECT given thrice weekly. Once maximal response is achieved, I will consider giving 2 more ECTs to look for plateauing of improvement and then stop the course of ECTs, sir.
Tell me something about the anesthesia procedure in ECT.
Yes, sir. In modified ECTs, we use an anesthetic agent, a muscle relaxant, and an anticholinergic agent. For inducing anesthesia, sir, we will use a barbiturate such as thiopental. Usually, the dose is 3 to 5 mg per kg body weight. Other agents like methotrexate, propofol, or etomidate, ketamine are also used. For muscle relaxation, once the patient is adequately anesthetized, upon ensuring adequate oxygenation, muscle relaxant is administered. Succinylcholine is used commonly at the rate of 0.5 to 1 mg per kg. It is a depolarizing muscle relaxant, and it has a very rapid onset of action and a rapid recovery. In cases of contraindication for depolarizing blockade, such as hyperkalemia, history of burns, pseudocholinesterase deficiency, or if the patient has OP poisoning or any other signs of neuromuscular disease, we can use non-depolarizing agents like atracurium. Anticholinergic medications, we give atropine or glycopyrrolate. It is usually given to counteract the vagally mediated bradycardia response during and after ECT.
And how will you minimize the cognitive adverse effects in this patient? You had mentioned something about that. So in your particular patient, what will you do?
Sir, I will minimize the cognitive adverse effects through one, ensuring that the response of the patient is monitored, and we do not give more ECTs than that is required. So that is basically the duration. Second is that I will use precautions to ensure that there is no prolonged seizures, so that cognitive adverse effects are lesser. Third is stimulus parameters. I will use an ultra brief pulse ECT, usually of a square wave and a longer pulse train and a shorter width. These montage will actually help me in reducing the cognitive adverse effects. And lastly, if in case I'm concerned about the cognitive adverse effects or it develops in my patient, I would like to change over to a right unilateral ECT montage, rather than going for something like a bitemporal, which is associated with significant cognitive adverse effects over the bifrontal montage, sir. I will also use the 1.5 times the supra-threshold stimulation for the ECT. And I would like to give, I would like to reduce the frequency of ECTs from 3 to 2 per week in case there are cognitive adverse effects. And during the procedure, I will ensure that there is adequate oxygenation, so that there is no need to give higher stimulus than what is required, sir.
Right. Go ahead with your pharmacotherapy management.
Yes, sir. Sir, in view of the fairly resistant nature of the depression in this particular patient, I'd like to start my patient on tricyclic antidepressant tablet imipramine 75 mg and increase the dose depending upon tolerability till a maximum of 300 mg. I'd like to also concurrently start her on tablet olanzapine 5 mg HS and increase it to 10 mg HS after 3 days. I would like to start her on tablet clonazepam 0.5 mg HS, which I will skip the nights before ECT. And I would like to keep injection lorazepam 4 mg IV SOS in case of any acute worsening of suicidal behavior.
Right. Justify your pharmacotherapy.
Yes, sir. Sir, my patient has failed to respond to more than 3 classes of antidepressants. And in view of the presence of severe depression with psychotic symptoms, the agent or the pharmacological class of choice is tricyclic antidepressants. And therefore, I am gone with a TCA, that is imipramine, in my patient, sir.
And what if she does not respond to TCA?
Sir, if she does not respond to TCA, already considering historically that the patient has not responded to SNRI, SSRI, and a combination of venlafaxine and mirtazapine, I'd like to consider MAO inhibitor trianylcypromine for this patient. There are other options which can be looked into, like addition of lithium or triado, that is T3, sir. Or in case that we cannot use any of these agents because lithium already she has not tolerated well before, I can even give a trial of ketamine in this patient, sir.
Fine. Proceed with your non-pharmacological management and
yes,
also
sir.
Your long-term management.
Yes, sir. Sir, non-pharmacological management, I would like to consider first psychoeducation to the patient once her capacity improves, and offers to the family members starting right away. The focus of the psychoeducation will be towards recognizing the early warning signs of recurrence, what is relapse prevention plans, and involve the other family members into establishing a link between stressful events and the prescription of an episode. Once the patient is better, we'll be able to explain all these things. Then in addition to that, I will improve the patient and the relatives' shared understanding of the environmental factors that increase the possibilities of recurrence. In an intermediate and a later phase, I would like to focus on effective family communication, better listening skills on part of the family members and the patient, and enhanced problem-solving skills. And I will also stress the importance of marital and family harmony in improving the long-term outcomes for the patient. Once the patient's psychosis symptoms improve, I'll initiate therapy for her, sir. I will consider psychotherapy for her. I would like to consider an eclectic approach in this patient, which has components of cognitive behavioral therapy and interpersonal psychotherapy. The sessions will focus initially on identifying key interpersonal problem areas like role disputes, role transition, deficits in interpersonal skills, and also grief. And then look at cognitive restructuring with focus on changing the patterns of thinking with respect to the cognitive distortions in this patient. in the continuation and the maintenance phase, in the long term, I would like to evaluate her comprehensively for the personality factors. I would like to kind of evaluate further about the anxious avoidant personality traits. And then in addition to the personality evaluation, I'll address the emotional functioning and the relational functioning, including her patterns of attachment styles and the current coping strategies that she's kind of using, including behavioral and experiential avoidance. And I would like to improve that through graded exposure to social situations, and also use components of cognitive behavioral therapy and social skills training to improve the access to deficit areas. In addition, I will assess the what are all the psychosocial factors that are maintaining the illness, that is basically the family factors, and address them through family therapy, continued family therapy intervention. I'd like to also liaise with the gynecological services and look at the evaluation and the management of the infertility, so that there is better liaison between the gynecologist and the psychiatrist. In addition to that, I would like to go for adaptive lifestyle modifications like brisk exercise. That there is exercise basically that makes the patient breathless, lasting for at least 20 minutes or more, at least 4 times a week, and keep the patient in regular follow-up and continued care to ensure that there is relapse prevention and that the patient actually kind of maintains the status of remission.
Can you define response and remission in depression?
Yes, sir. So generally, when we say non-response, we mean there is less than 25% improvement of the severity as compared to the baseline, as rated on a standardized rating scale such as the HAM-D, that is the Hamilton Depression Rating Scale. When we talk about response, we talk about an improvement of more than 50% of the symptoms from the baseline, and the improvement seen is if it is more than 50% but less than the threshold that is required for remission, it falls again into the response category. Whereas in remission, we talk about a status wherein the person is virtually asymptomatic for at least 2 consecutive weeks. And we talk about recovery when the patient fails to meet a criteria for a major depressive disorder for at least 8 weeks duration.
In your patient, what are the major factors which indicate high suicidal intent?
Yes, sir. So my patient actually has a lot of indicators of high suicidal intent. First was that the act was carried out in isolation, and so the act was timed at a time wherein intervention was unlikely. Second is there was a lot of precautions taken to avoid discovery, like she tried hanging in a different room than the ones that the parents were sleeping in. Third, she took precautions in anticipation of the death, in the sense that she sent her last message to the husband, and so she made sure that the preparation was in place. And so in essence, it was also a premeditated act in which she had actually kind of bought the rope well in the daytime and kept it under the pillow because she wanted to perform the act. All of these are indicative of high suicidal intent, sir.
If I remember correctly, you wanted to rule out bipolarity.
Yes, sir.
How will you differentiate unipolar and bipolar depression?
Sir, bipolar depression has an earlier age of onset. Usually it is less than 25 years. There are usually history suggestive of multiple episodes and family history of bipolar affective disorder. And clinically also, bipolar depression might be associated with some atypical features like hypersomnia, hyperphagia, weight gain. Additionally, it is associated with more retardation, what we call as a laden paralysis, presence of more psychotic symptoms, pathological guilt. There is emotional lability that can be seen in the episodes with irritability and racing thoughts, sir. All of these point towards a bipolar depression than a unipolar depression.
Tell me about a study about treatment of depression. Any important study you know of for treatment of depression?
Yes, sir. The STAR D trial, sir. STAR D trial was an important study.
Trial.
Yes.
Tell me about it.
Yes, sir. Sir, STAR D, it was an NIMH-funded pragmatic clinical intervention study in depression. It stood for sequenced treatment alternatives to relieve depression, sir. So there, they used a sequenced treatment alternative strategies wherein they showed that nearly 2/3 of the patient who were actually kind of enrolled for the study had a comorbid psychiatric diagnosis or a physical disorder, and almost 40% of them had onset less than around 18 years of age, which is why this is often called as the most pragmatic study or the real world study, which reflects what is the situation on the ground or the real world findings. It had 4 possible steps of treatment. And in each step, if the patient failed to meet the remission criteria, they moved on to the next level, sir. And in each level, there was more than 1 randomization options available. So these are the unique things I remember about the STAR D trial, sir.
Tell me more about those 4 steps. Tell me the salient features.
Yes, sir. Sir, step 1 was everybody received a flexible dose citalopram treatment strategy. And if they were in remission, they entered a naturalistic follow-up for about a year. If there was no remission, they moved to step 2. Step 2, there was either an augmentation strategy or a switch strategy. In augmentation strategy, they tried either combination augmentation with bupropion or buspirone or CBT, or if they switched to either bupropion, sertraline, or venlafaxine or CBT. If the patient again entered remission, again a 1-year naturalistic follow-up. If they didn't enter remission, they went to step 3. In step 3, they used again an augmentation strategy or a switch strategy. In augmentation, they tried either lithium or T3, and in switch strategies, they tried nortriptyline and mirtazapine. If in remission, they entered again a 1-year follow-up, or if not, they moved to step 4, which was the randomization to either tranylcypromine or a combination of venlafaxine and mirtazapine, sir. The take-home message was that the cumulative remission rate after all the 4 steps was 67%, or what we call as 2/3. And the cumulative non-response rate was about 1/3, 33%. So about half the participants in the STAR D trial became symptom-free after 2 treatment levels. So these are some of the facts that I remember from the STAR D trial, sir.
How do you define treatment resistance? Give me a classification if you know.
Yes, sir.
Treatment resistance in depression.
Yes, sir. There are various classifications given for treatment-resistant depression. One I remember is by Thays and Rush. So Thays and Rush actually classified it into 5 stages. Stage 1 was wherein they said there was a failure of one adequate trial of one major class of an antidepressant. Sori et al. Even added to this, saying that it is around 250 to 300 mg of imipramine equivalents given for at least minimum duration of around 2 months or 8 weeks. So stage 2 is wherein in addition to stage 1, there is failure of one more adequate trial of a distinctly different class of an antidepressant from what was used in stage 1. Stage 3 is, in addition to this, there was a failure of response to TCA. Stage 4 is, in addition to this, there was a failure of response to a MAO inhibitor. And the stage 5 is wherein, in addition to all this, the patient also failed a course of ECT, sir.
What are the risk factors for resistant depression?
Sir, risk factors for resistant depression overall are features such as younger onset, comorbid anxiety disorder, personality disorder, comorbid substance use, chronic medical conditions which are usually incurable. All these indicate that a worse prognosis and a more resistant trajectory of depression.
Is your patient's condition qualifying for treatment refractory depression?
Refractory? No, sir. Sir, as per Thays and Rush criteria given in 2017, for the patient to be called as treatment refractory, for the patient to be diagnosed with treatment refractory depression, the patient should have failed several antidepressants, at least 3 minimum trials of different drugs and classes, several adjunctive drugs, at least 2 different trials with different medications, and at least 1 course of ECT and at least 1 trial of adequate psychotherapy, sir. So because my patient does not qualify for this, she doesn't suffer from treatment refractory depression, but she does suffer from treatment resistant depression, sir.
How will you rule out pseudo resistance?
Sir, usually there is a dictum that there are 5 ways which we need to look out in pseudo-resistant depression. That is, if we have not given an adequate dosage of the medicine, or if the patient has not been adherent to the medicine, or if there are significant access to disorders which have been undertreated or untreated, if there are alternative diagnoses like a comorbid PTSD or which is actually not picked up, which is masquerading as depression, there is absence of therapeutic blood levels, and therefore we do not know that the patient has adequate levels of antidepressant in the blood, which might be secondary to other pharmacokinetic interactions, altered metabolism, or if there are poor extensive metabolizers. So all these factors indicate that the patient might have pseudo resistance rather than true resistance, sir.
How long does an untreated episode last in depression?
Sir, usually they say that a natural untreated course of depression lasts anywhere between 6 to 13 months. But most treated episodes usually last for 3 months or lesser. But as the course of the illness progresses, patients might have more frequent illnesses with more longer episodes, sir.
You mentioned that you wanted to do psychotherapy.
Yes, sir.
And can you name a few cognitive distortions in depression?
Yes, sir. Some of the common cognitive distortions seen in depression include arbitrary interference, selective abstraction, overgeneralization, personalization of things and patterns that are actually happening, magnification or minimization, and dichotomous thinking.
Related to therapy, anything other than CBT will consider this?
Yes, sir. Sir, as I stated, I would like to consider an eclectic approach with components of CBT and interpersonal therapy, because in this patient, there is a tendency of life events and role transition or disputes leading to the episodes. Initial therapy sessions can focus on establishing an association between the life events and the depression, letting the patient have the sick role, and reframing the state of her distress as not secondary to herself, but actually secondary to the disease. Middle phases, I'll focus on the interpersonal relationship between the family of procreation and the patient, and patient's anger as a normal interpersonal signal, and to encourage the efficient expression of that anger rather than actually internalizing it. Lastly, I will focus on role transition and bringing her to reflect on the gains that are sustained during therapy so that she can maintain the remissions.
Last question, prognosticate your patient. Give me good prognostic factors and poor prognostic factors.
So the good prognostic factors in my patient are that she is married, she has a good education, she's in a stable job, there is absence of any substance use, and there are no significant medical comorbidities that the patient suffers from. And she's been largely adherent to treatment. Whereas there are several poor prognostic factors like female gender, multiple episodes having almost no precipitating factors, breakthrough episodes despite being on adherent to medicines, presence of family discord, treatment resistance, early onset, and of course the presence of personality disorders. Overall, I think that there is less favorable prognosis in my patients, and that's what I have to say about the prognosis in my patients.
Thank you. That's all for you.
Thank you, sir.